All right, guys, welcome back to the podcast. Today, if you pull up your industry overview, which is available on our website at pawhealth.net/PAWCast, the PDF with our industry overview has the several different sections. Today, we're going to be focusing on service, or sort of our lack of infrastructure within the industry. The previous segments, of course, were on culture and talent, but currently we're focused on the middle portion of the industry overview, and today being service.
Welcome to the podcast.
Today, we're talking about service. Within the service bubble are three key factors that we have included in there are at-risk households, failure of population control, and third being the antiquated business practices. And I know in our conversations that we talked about within culture and in talent, we've referred to some of these points, but today we're just going to take a deeper dive just to make sure that everyone knows what's going on within these industry overview, because this is the last part of getting a full picture of the problems that you had seen years ago, and we're now starting to explore some of these solutions and fully implement them in many cases. So to start off with, we can pretty much just pick one and say, basically, what do we mean by this? And just to start at the top, at-risk households. What did you kind of mean by that, Dr. Carlo?
Yeah, so I think, again, like you had said, this is kind of the last piece to the problems we've identified within the profession. But really the way that we've gone through this is what tells the story to end with business. Mm-hmm. Again, I think, yes, business and a lack of infrastructure is one part of the issue within our profession, but the other ones, I don't want to say these are all equally weighted. Mm-hmm. They all do sort of work together, some more severe than others. But really when you look, like you said, at the at-risk households bubble, really what we're talking about is a combination of problems within public relations, problems within wellness and engagement, problems within culture. That's kind of why I have it up into that corner of mm-hmm. the hexagon, is because it really does have so many different pieces that we are not, that we are sort of adding to. And like you said, let me go ahead on to explain. So let's kind of revisit some of the culture stuff, just very temporarily.
Mm-hmm. Yeah.
So, because we can always go back to review those. But when we start to talk about this failed bond spectrum alignment within culture, mm-hmm. and we then are starting to say, okay, well, we're having more animals per household. Maybe we're not all really defining those households all the right ways, or at least uniformly. I guess the definition's there, but I guess the uniform definition, sort of how we have it at PAW, where everyone's a caregiver. Like it's whatever your attachment is to your animal is how we're going to support your attachment. We're not going to impose anything upon you on how you should or should not have this attachment to your animals. Mm-hmm. But when we start to look at sort of the lack of infrastructure sort of within the business side, and sort of the uniform business practices, and of course the antiquated business practices, but then we start to pull culture into that bubble and saying, well, what is an at-risk household? An at-risk household is too many animals who don't have enough care.
Okay.
That's ultimately the definition of at-risk household, just too many animals who don't have enough care. Mm-hmm. Now that is different. That is not, again, uniformly defined, because you can have one animal in one household who has zero care versus 10 animals in one household with top-end care. So mm-hmm. it's not necessarily on number. It's more so on saying how, as an overall whole, is this household caring for the animals based on its own individual definition of the human-animal bond, or where the human-animal bond spectrum is. So if we take that and saying, well, there are these at-risk households that maybe we haven't identified, maybe we have identified them, but we haven't engaged them appropriately. Because remember, the at-risk household is close to the wellness and engagement and sort of the public relations. Mm-hmm. If you look through public relations, there's several solutions there between active engagement, passive engagement, shelter engagement, so on and so forth. But if you look into these at-risk households, maybe we've identified them, but we don't necessarily have a infrastructure that supports them. And this is what we're talking about for the middle 60%.
Right.
So, when we start talking about top bonded practices, which again, we come into this antiquated business practice sort of thing. We'll come on that in just a few minutes. But coming into the at-risk households and saying, well, maybe we have identified them, but there really isn't an infrastructure for us to help. If you're in a clinic where, it's a lower volume practice, a higher cost practice. Usually those two things go together versus high volume, low cost. That's kind of the two spectrums there. But if you were in a setting where as a veterinarian or a veterinary technician or just part of the medical team where you're in a higher cost clinic and you're turning away business, then okay, we are perpetuating sort of the at-risk household category.
Right.
Versus, sort of the other way is if we have sort of a, sort of high volume, sort of low cost clinic, then maybe the quality of care that they're getting isn't helping them identify to keep the whole household healthy, and saying, maybe there's chronically managed diseases that haven't been identified. We have a feline patient who has a chronic vomiting condition, or we have a canine patient with a chronic ear and skin condition. So, and sometimes in your high volume practices, there just isn't the time to really sit down and have a 30-minute consultation on just skin problems.
Right.
So that's when we start talking about these sort of at-risk households. That's just one sort of bubble of at-risk households, because the next thing is that it touches onto failure of population control.
Yeah.
So, I think, pretty much anybody who was homesick from school, like 90s through early 2000s, like that, like the Americana of staying homesick from school
Price is Right.
is The Price is Right, and I think all of us have grown up hearing, Bob Barker, say, get your pet spayed and neuter, get your pet spayed and neuter. I remember very, very young, I didn't know what he was talking about. I was like, okay, Bob, like that's a really weird way to end the show.
But I agree with you for some reason.
Right. I mean, because one, I love the show and you're awesome. So let's just say that,
And thank you, Drew Carey, for continuing the tradition.
Absolutely. And honestly, that was another one. I'm not get totally off topic, but I mean, Drew Carey, like, could they have actually chosen anyone better?
I don't think so.
No, they don't. I think he took the reins wonderfully well.
Yeah. And he's grayed.
I know.
It's even more appropriate now that he's grayed.
I feel like that. I feel like they're doctoring it up for the show. Like,
Absolutely.
I feel like they had to gray him
Yeah.
to make him slide in.
Dude, I watched a stand-up special with him, and he had brown hair. 100% the gray is doctored.
I knew it.
Regardless, Bob Barker did put a big emphasis in his life from a mantle that was completely unrelated.
Yes.
To touching on this idea of population control.
Population control.
And this was, The Price is Right was around for 40 years.
Yeah. It is a part of who we are as a country. So everyone always hears that, right? So it's get your pet spayed, no, get your pet spayed, get your pet spayed. When we start talking about failure of population control, that's where, like I said, it sort of ties in with these at-risk households. So when we start talking about failure of population control, part of it is the discussion that we kind of touched on with culture is saying that there's more animals per household. So, more cats, more dogs per household. And plus part of that 90s transition, 80s transition, where now more animals are actually in the house versus yard dogs and farm cats and so on and so forth. But with that, when we start talking about this failure of population control, there really isn't the systems in place for us to adequately control the population are overwhelmed. So when we start to talk about all the animals that need to get spayed and neutered, that's sort of the industry side and saying, well, we need to be spaying and neutering these animals, but at what cost? So what are veterinary clinics charging? Again, are they in a high-cost, low-volume clinic? Are they in a low-cost, high-volume clinic? Or are we saying standalone services being performed by spay and neuter businesses who just do low-cost spay and neuters versus humane societies and all of these different types of things? But the reality is, if we were doing a great job with population control, our shelters wouldn't be overrun. We wouldn't be having thousands of animals being euthanized per day. We wouldn't be having a rescue system at all. When we start to talk about saying, well, now the shelters are overrun, we're starting to split shelter definition into a kill shelter versus a non-kill shelter. So now we even have this, but then everyone, even your non-kill shelters, for the most part, are usually pretty packed full. So there's usually a waiting list to get on no-kill shelters. So the waiting list for a no-kill shelter means that more animals are then shifting back to kill shelters, which again is just part of what it is. I mean, when there's just so many animals, like I said, this failure of population control. But then we're actually starting to see now where the rescue systems are being overwhelmed, where there really weren't any rescues in the 90s. I mean, they were there in some capacity, but not nearly as much as they are now.
Well, they were the Sarah McLachlan cases.
Yes,
when it was.
Oh, yeah.
It wasn't just everyone ended up at a rescue.
Correct. Yeah, it was very, very isolated instances, isolated circumstances, and it was again kind of a low volume type thing, taking the spill over special cases, like you said. Like you're saying, exactly true. But now it's where we have your sort of true nonprofit, 501c3 nonprofit rescues are packed,
Right.
and you'll find that there are, so now everyone is sort of starting to create rescues where maybe they themselves had 2 or 3 dogs, and maybe they got up to about 10, 15 dogs, and they're like, well, I can start to place these dogs into good homes. I know good people. And then they sort of like adopt into the sort of rescue side. Some of them are incorporated, some of them aren't. Some of them are actual true nonprofits, but then even within the nonprofit, the actual organized nonprofit rescues, there's no standard, on how they're supposed to operate, what their, articles organization, all those different type of things on how they're actually structured. It's just, I have a nonprofit now, I'm going to rescue animals. Well, the question being, well, how much veterinary integration is there? How much is your, sort of disease management and population management protocols actually under the direction of a veterinarian, one that you trust, or however that works? Or is it something where the majority of your information is coming from online, from Facebook, so on and so forth? So anyway, so we're just talking about rescues right now.
Yep.
But then we say, okay, so, shelters are overrun, shelters are split down into kill, no kill. Then we're saying rescues started to come up. Rescues are now overrun. And now we're jumping to the other side where now there's just people who are starting to take on more animals. Where I'm not just saying increasing number of animals per household, but now we're saying like, when someone finds, stray kittens on the side of the road, 2 or 3 stray kittens on the side of the road. Well, now it becomes, well, I'm not, the kill shelters, I'm not going to put these kittens in a kill shelter. There's no non-kill who's taking kittens right now. There's no risk kitten rescue in my area, and I don't really know what to do with these kittens. It's like, well, I'm just gonna keep them in my house. I'm just gonna have 3 more cats now,
right?
And eventually, yes, they may find friends where they can send those kittens off. But again, when we start to then kind of merge the line between at-risk households and failure of population control, now we're starting to say where with the at-risk household category, where maybe it was 1 cat they couldn't afford, 10 cats or 10 dogs or patients that they could afford. Now what we're saying is because of this failure of population control, now we're starting to stretch the budget thin. So if it was one of these households where, they had 2 patients, whether 2 dogs, 2 cats, a cat, a dog, just 2 patients, and they could care for them very, very well. Well, I think, almost unanimously across the board, the culture of America is that we're animal lovers. So, again, isolated pockets, individual preference, so on and so forth. But as a whole, we are a nation of animal lovers. So if we say that we are doing a really good job in this one household, budget-wise, monetary-wise, that we can care for these 2 patients, and then we just pick up another one, we just pick up another 3, whether we, like I said, found those cats on the side of the road, found a dog on Craigslist, found it in the Walmart parking lot, wherever these animals are coming from.
Yep.
Now what we're saying is, because there's just so many animals everywhere and there's this failure of population control, is that it's making our at-risk households worse. Because if they could have cared for 2 patients very well, you don't make more money by then bringing 3 animals into the house.
Yeah.
So you have still a finite budget on care, where then you're going to start to shift your household. Your household now becomes at risk, where you had 2 patients you could care for. Now you have 2 and 3 puppies or 2 and 3 kittens that you can't care for.
Right. It's increasing the quantity, but it also is lowering, or it's increasing the risk for the ones that were already there too.
Correct. Yeah.
So it's higher quantity and higher risk at the same time.
Yeah. No, risk is a really good word for it, because there's financial risk, but also disease risk.
Right.
Like, biosecurity. So, for me, I'm probably one of the most strict veterinarians when it comes to biosecurity. I want a month. I want a month from when a new kitten comes into the household before it's introduced to the other animals in the house, because respiratory issues, most of your respiratory viral infections to most of your intestinal parasites have 2 to 4 week life cycles. So you can have a patient that tests fecal negative, but they got parasites in their gut that are going to shed eggs within a couple of weeks, but they're not going to test fecal positive until 4 weeks later. So for me, it's like, no, I don't want anybody commingling.
Yeah.
We're going to have years and years and years and years and years where these animals can live together. Can we just take a month off? Can we have a little break for, the first 4 weeks to make sure everyone's right between vaccines? So again, risk, right?
Right.
So we're saying the risk of the household is even higher than from a disease standpoint, from a monetary standpoint, from a patient care standpoint. So that's when we start to look at sort of this lack of infrastructure. It then sort of comes down to how do we appropriately identify these at-risk households, and before we even start talking about the population influence, but when we start bringing it back to how do we sort of identify these at-risk households, and what sort of infrastructure do we have to help these at-risk households? So if it is a household where they have 2 patients they can't care for, how can we help them? How can we identify them? But then also when we start to bring the population portion into it, is they had 2, now they have 5. What infrastructure is there to help these people? And the thing is that there isn't for either. Is that we as veterinarians, as technicians, I mean, when it's like, oh yeah, so-and-so has 5 cats or 6 cats or 8 cats, and it's like, well, this is what they're going to be able to do, and we're going to try to do our best for these people. But then the same thing is, when we have these at-risk households and then they don't have enough money to spay and neuter, and then, their, 2 becomes 8, just
quickly.
Quickly.
Yeah.
So that's also part of this sort of failure of population control is, that patients probably aren't being spayed and neutered at the frequency that they should.
Yep.
And I think I think we're very, very good, thanks to you, of course, is when we talk about fault, it's really more so on like the accountability side, and saying there really isn't a fault. I mean, we can, on one hand, blame veterinary clinics for charging too much, right? But I don't know if that's really the problem. We can go the other way and we can blame people and being at fault for not having money for taking on this responsibility, but it's actually way more complex than that.
It is,
because like I identified a few minutes ago, is it's not a matter of vets charging too much and people not having enough money. That is definitely one part of it, but a part of it is there's just so many animals everywhere. Is we have failed population control.
Yeah. Well, the concept, again, going back to the thing that we've touched on every time, is this idea of the top bonded practice, the top catering to the top 20%, developed the pricing structure ages ago, and as the frequency, or I don't know, the quantity of animal ownership has increased across the entire spectrum. Those that are in the middle 60, especially the lower half of that, basically what happened is they were completely uncared for, and then that it was an exponential increase in population in a very short amount of time.
Absolutely.
So what needs to happen now, to a point, is some janitorial work.
But yeah,
I hate to put it that way, but it is cleanup, because there was the lack of service, the lack of infrastructure that happened for 20 years, something like that, 15,
15,
something like that, when it really started to turn over into a lot, most households owning a pet, that transition, then the pricing model didn't keep up. Not to say, again, can you put the blame on either side? I don't think so. I don't know, and I don't know if it really is positively impactful to blame either side either way, because I have no desire to blame the people for wanting to care for animals. Because the closer that they are to them, I would agree that the more likely they are to care for them. But also from a veterinarian's perspective, especially after 2008, why would I try to cater to the people that don't have any free cash flow anymore?
Right.
And I think that's a big contributor to what halted any progress that may have happened between 2004 2008.
Absolutely.
When everyone, there was a whole lot of money that was put into the system. And then everyone lost all of it. And then it just stopped. It just this is the pause point, guys. And I would say the kickstart to get back off of that has, I don't know if it started. I know it started with us. But it seems like the pickup to continue the progress has been very slow. But the population control problem has not stopped. It has only continued further and further and further along.
No, absolutely. And I think right in the middle there, you had touched on one point as well, is like that desire to care. And that's again in tandem with then how, when we were talking about, sort of our failed bond spectrum alignment and culture, that was sort of how we were talking about it, was that, you have this relatively middle to high bond spectrum alignment as a whole in the country. Now, again, you have people that kind of flip everyone, but for the most part, we're tipping into this anthropomorphic.
Trending higher, for sure.
Yep, we're definitely trending in that direction. And then again, like you said, the monetary component to it. So it still then comes into these at-risk households and this failure population control, is that we have a lot of lovers, a lot of pet lovers. And it's just, you have more animals, you want to care for them, you don't want to see them. And that's the same thing for us on the veterinary side. You don't want to see bad things happen to them. You don't want to see these things. But also at the end of the day, it's like, you don't want to miss meals, you don't want to miss mortgage, you want to miss this, you want to miss this. And I think it's one of the great things that again we learned from you, but also in part of our own problem solving process, is it's never fruitful to really focus on blame.
Right.
If we want to really sit down and just hash out this conversation, like, I think you're at fault and I think you're at fault, it's like, where is that actually going to get us?
Nowhere.
Right.
My favorite, I know this is a reference that'll fly over a lot of people's heads. My favorite South Park character ever is Captain Hindsight. Did you ever see that episode?
Yes.
Because it is so. They do a phenomenal job of making fun of everyone, but that character is exactly what you're talking about. Is like, he might be a superhero that can see everything in the past and what we did wrong, but he doesn't get us anywhere positive. And that's So
I told you that's the gift I have, right? Like, I have the gift of hindsight.
Yes. Yeah. I think we touched on that in episode 2 or 3. But that's and that is important, because it does allow, as they say, study history so you don't repeat the same mistakes.
Correct.
But don't just study it to point blame and then say, well, there's nothing I can do about it now.
Right. No, precisely. Yep. And I think that's where, when we kind of get into, on sort of the left side of our industry overview diagrams, we start talking about wellness and engagement. We start talking about shelter engagement. We kind of get into these solutions. That's the exact point, is for us, and I know people have hopefully sat through hours of content now leading up to the service component to this. I mean, we may have lost some people along the way.
That's okay.
That's fine. But I think, again, the reality here is that we really aren't belly aching about this, and we do have solutions to come out of it. But when we really start to talk about, the at-risk households, to failure population control, no one is helping themselves. I mean, and I'm not saying people aren't trying, but I'm just saying with the whole circle between the saturation of shelters, the saturation of rescues, the saturation of households, it's just, where's the money come from? Where's the talent come from? And I think that's where, when we start to look at kind of those two variables, why it is so incredibly important that universities to students to veterinarian to veterinary clinics is that we integrate so hard into the shelter system just to focus on biosecurity and spaying and neutering patients, reducing population control, and then getting into these households, like I said, these at-risk households where it's, they have the 2 patients and they can care for 2 patients very well. It doesn't help those people to see a cat or dog on a shelter website or, a rescue website or something like that, where there is an expectation of care, where it's like, oh, this animal has been vetted, we've dewormed it, we've looked at it, this is a little bit of an older patient, but really, like, the full context of this animal's medical history probably isn't tracked. One, they may not know. However, the next is then going to come to the veterinary talent that is working in the actual shelters themselves, is to say, well, what is the competency of this veterinarian? Is there actually a certified technician there? Do they have any diagnostic capability, or is it someone coming through just doing certificates of certified veterinary inspection, the CVIs, where it's just like going in, yep, they look all right, sign off on the paper? Or is it, oh, this one actually has really terrible dental disease, that one actually has pretty significant and advanced skin problems. This one has this one has this one has urinary problems, this one has this. And we also then have diagnostics to back that up. So how many shelters, whether they're kill or no kill, how many rescues, whether they're assembled or non-assembled, to then how many households, whether they're, private individuals, how many of them actually have access to unlimited veterinary care to identify the true needs of the animals in the shelter when there's already too many animals in the shelter.
Right.
So that's then where we're saying, even if you go through the proper channels where you're someone who has, 2 patients in the household. You can afford 2 patients in the household. You're taking care of 2 patients in the household. No problem. You just want a third. Just want a third cat, second cat. Whatever it happens to be, that's fine. I mean, more power to you. You have an expectation that you've received now going through an adoption process, whether it be rescue, whether it be shelter, whatever it is. You say, oh, well, this patient was cared for, and it's a little bit older, may have some needs, and then you adopt it, and it's like, oh yeah, this one I guess does vomit a little bit more. Oh yeah, this one actually kind of has some bad breath. And then you take that patient to a veterinarian, and it's like, oh yeah, there's probably $1,500, $1,800 in dental work. It's got a bad heart. It's got these issues, these issues. And the people weren't expecting that.
Right.
They weren't expecting this huge medical bill. I mean, maybe they knew they were getting an older patient or whatever it happens to be, but they didn't know that much.
Yeah.
And so then it comes back on the shelter system. So like I said, this is all coming back to our lack of infrastructure.
Right.
Is for us to then say, well, there's no uniformity between kill, no kill, and even between kills, there's no uniformity, to then say well, you rescues and everything else. If we don't have at least an infrastructure of the expectation of veterinary care with the patients in these organizations, and the people then adopting these animals are then inadvertently turned into an at-risk household, they were just doing the right thing.
Yeah.
It all comes it all can potentially come back to the shelter, where then that's a negative PR move for them, where it's like, I just adopted this, cat from you guys, and I didn't know it was this bad, and you guys need to take it back. And they're like, well, we told you it was older, and you knew what you were getting yourself into. And there are some shelters, again, not uniform, but some of them, it's frowned upon when the animal goes back, and it's like, well, it was your responsibility to care for this animal. It's like, well, I wasn't totally informed of the severity of the problem at the time of adoption. So, and it's not to say that the shelter was necessarily withholding any information. It was just they didn't have it.
Right.
And again, it all comes back to sort of the creation of these at-risk households. Whether we're talking about are we identifying illnesses early enough? Are we having affordable services? Is there available services? And it's where people have access to it at all parts of that spectrum, from the no kill to rescue, assembled or non-assembled, to the individual households and everything else.
You had meant the way that you worded that. I don't know if you realize how good it was, but it is. No. You said the creation of at-risk households.
Yes.
Outside of this industry, just with the exposure that I've had in different worlds, the concept of creating risk is something that I feel, and I could probably factually back up at some point here, is that no business model is out to create risk without a significant amount of reward on the back end of it, right?
Sure.
So the reward in this case being, if I'm a caregiver, I go to the shelter, I adopt an older patient, and I understand that I'm at risk for both my emotional health to a point. I'm going to get attached to something that's probably not going to be around for terribly long,
Sure.
Or potentially ill. If I understand that, I'm willing to take it on.
Sure.
The reward,
which some people are.
The reward being the emotional attachment, fulfillment, whatever it might be.
Yeah.
But from the shelter's perspective, and from the veterinary world's perspective, just as a caregiver, wouldn't you say then it's kind of our job to mitigate as much of that risk as possible? Because really, what you're saying is there's not any quote unquote monetary gain for the individual that's taking on the risk.
Correct. There's not. No, how could there be?
Right. So
unless
somebody
for some
has
reason
to mitigate that at some point.
Unless there was animal flippers, right? Where it's like you're taking an animal from a shelter that needs an incredible amount of work. You're taking it in your household. You're going to flip this animal to being super healthy, and you're going to sell it for a profit.
Right.
That's like
it doesn't happen.
That doesn't happen. Nobody does that. Again, you're right. It's entirely emotional. That circumstance arises,
which is valid.
Yeah, which is valid. Yeah, there's no problem with that. It's just coming into the culture part.
But the concept of I'm going to acquire this animal. Yeah. I'm going to sink $2,000 to $5,000 into it over the next 3 years.
Right.
Like it's not even so much that they're not willing to do it. It's just it doesn't it's
Yeah.
not.
Tangible.
Most people would say
Yeah.
it's not logical to do that.
Yeah.
I guess was the
Yeah.
easiest way for me to
Yeah.
put it. It's
Yeah.
not rational.
Yeah. Yeah. I think, certainly if you're in the world of, sort of independent wealth, where it's like we can't do these things because we have the means to do it, then by all means, I mean,
Right.
whatever. But again, no, I think there's an incredible amount of emotional reward
Yes.
by getting these patients from the shelter and then bringing them in your household and be like, you know what, I got my patient, and this is part of our human animal bond discussion was, it used to be where you just went and got a dog or a cat from a shelter. Then even you can hear me say it. It's, well, you're adopting a dog or a cat from a shelter, but the terminology used now is I'm rescuing a dog or a cat from a shelter. I'm rescuing it from a rescue organization. I rescued it from Facebook. There's this the terminology change in that capacity is one of the subtle sort of implications of the people who are doing this type of work and where they fall in the culture bound spectrum alignment is that they really do feel that they are at the service of this animal. They are coming to the need of this particular patient. I'm rescuing this animal. I don't know if too many people who run into a burning house to rescue a dog out of a burning house. I mean, there's firemen, they're doing a lot of EMTs.
Right.
I mean, that is there. But like the real terminology rescue, that is a very literal sense that they're being rescued from, death and dismay, which then has bled over into saying, well, when they come out of a shelter, I'm rescuing. When they come out of this, I'm rescuing. So that's the emotional component to what it means to get an animal in today's world. And we say the creation of these at-risk households is that what they're taking on is they already have the mindset that they are now in a position where they are the ones who are solely responsible for caring for this patient, which I'm not saying that they aren't, because once you then bring that animal into this household, you are responsible for the care of that animal. But it comes back to what I said a few minutes ago, is it's a matter of understanding. It's a matter of, forethought. It's a matter of, really even informed consent to a certain degree.
I was going to say,
it's
informed decision making.
Informed decision making.
Yeah.
And I think that, and I don't know again if this is a culture or not, but I think we do a really good job of making uninformed decisions all the time.
Oh, absolutely.
I'm saying like we as a company, but I mean just people in general do a really good job of just like, well, I'm going to do this now because I'm doing the right thing for this animal. But then when it really starts to hit, and it's like, well, we have a problem with population control at the moment. There's too many animals. Most of those animals aren't getting the care that they need in this particular setting, of course. Like you said, then the creation of these at-risk households, and then it comes back to what the discussion always is: who's at fault, who's at blame, and who's responsible.
Yep.
So, like I said, I think while yes, the individual caregivers are responsible for the care of the patients that they bring into their household, there is a certain amount of responsibility on the veterinary side to say as well, and to say that we need to have affordable health care. We need to have affordable wellness. We need to have affordable preventative medicine. We need to have, affordable spays and neuters. We need affordable vaccinations, so on and so forth. And again, I think it sort of comes back, and it's now starting to touch onto the antiquated business practice component and saying, well, it is our responsibility in a certain capacity to figure out a solution for people who don't even know they have the problem before they even have the problem. So we need to then create a business, and this is that infrastructure component, is that we live and breathe veterinary medicine all day. The whole team between caregiver support, medical support, technicians and veterinarians, we see the same stuff. If you keep your eyes open, you see the same stuff all the time.
Well, yeah, you even alluded to it in the episode about culture. It's you can only practice medicine for so long without being like, I know what this is. It's
right.
As long as you're observant.
Yes,
absolutely. And you can see it from many different perspectives.
Yeah. I mean, it's like when, patients come in, canine patients come in requiring a C-section, it's pretty much the same story every time. It's either, at one point in time, we're planning on getting this dog bred. At least once we were going to plan it, and so we had all the necessary money and all the things related around it to proper care. But then it sort of happened accidentally, or it was one where I really wanted to get my dog spayed, or I really wanted to get my dog spayed. But it was just I kind of live a paycheck to paycheck life, so I never have really had the opportunity to get it spayed. And then it tied with the neighbor's dog because none of us have our dogs on leashes, or they did it through a fence, which is crazy, but it happens.
Oh, yeah.
So it's kind of these like same variables every time, where when these patients come in, it's like, oh, well, that's obviously why they're here. So coming back to the whole point here is that we live and breathe these things every time, and usually most problems have the same predisposing factors. Hit by cars, they always come in for pretty much the same reasons. This is what led up to the hit by car every time.
Yeah.
C-sections, this is what led up to it almost every time. These three variables. So what we're saying is, from an antiquated business practice standpoint, which is again a kind of a big bubble in of itself, is that, just like I said, we need to anticipate what it is they're coming in with. So how do we as a company prevent everybody from having C-sections? How do we prevent everybody from having hit by cars? How do we prevent, now that's like trauma and that's illness, but let's take it the other way. How do we prevent dogs from coming in with heartworm disease? How do we prevent dogs from coming, patients coming with all these very things? So even older patients, older feline patients with kidney disease and kidney failure, how do we actually get to that point of prevention and saying, well, let's catch this before it's a problem, let's prevent this before it's a problem? We have a lot to gain as a company, as a business, as an industry, if we just establish that infrastructure for the majority of households, rather than, like we had said before, rather keeping it at the top bonded level, but we have to create a business structure that already anticipates all of the problems that people are coming through the door with and prevent them from ever coming in. Yeah.
But you just said it though, like that mindset is from a purely capitalist perspective, is back asswards.
Sure.
Because you take a C-section case, where an average C-section costs $2,000, maybe, I don't know, whatever.
Yeah.
Let's call it $2,000 for a nice even number.
Yeah, sure. Why not?
A spay procedure costs $200.
Right.
As I don't know,
number.
General number.
$150. Yeah,
so you're taking 10 times less money.
Yeah.
Because out of essentially anti-capitalist or altruistic, we in this instance would call it altruistic motive, which if you consider the fact that it is a top-bonded practice, the idea of being top-bonded is I'm going to do the most financially gaining item. Again, when I alluded to the concept of production in medicine, that's kind of what I was getting at, where it's like, oh, wouldn't you lean towards the $2,000 procedure? Wouldn't you lean towards these bigger numbers? But the catch of that whole thing is, and that I've started to notice being in the clinic a whole lot, is that if you can have a wellness patient for 10 years that doesn't get a C-section, you end up in the same place, and you end up with somebody that's going to show up every year.
Yep.
They're going to spend their $200, $300 a year, whatever it might be. Yeah, you're going to do a little bit more work along the way.
Yeah.
But you're serving the patient.
Exactly. Absolutely. No.
So you end up in the same place.
Yeah. Exactly. Yeah.
But it's really you're kind of stepping over $1 to get to the different dollar, or or stepping over $1 to pick up 10 dimes.
Yeah, right.
It's just it takes some time to pick up each one.
Right. Yeah.
You still end up in the same place, and you're not really sacrificing, assuming that you're doing your job well on the wellness side, and you're able to serve multiple types of people at an affordable rate.
Yeah.
But you're essentially in the same place.
Yeah. No. Yeah. 100%. Yeah. I think that's a big takeaway. When we start to look at saying, you're exactly right. True capitalism, you are going to race towards the $2,000 sale.
Right.
That is what you want to have done. But it's accidental. I think a lot of veterinarians, it's not like we have this thing. It's like, well, I'm not going to spay anything, because as long as I still have C-sections, or I still have uterine infection, or pyometra is the other one, that, it's the same story. It's like, it's not like we have this conscious decision where it's like, oh, we're not going to spay so that we can make, 10 times the money on one of these other procedures. It's that because there's a failure of population control, and because we have these at-risk households, it's like, that's the name of the game, is we just don't have patients who are spayed and neutered. We just don't have patients that have been vaccinated appropriately. We just don't have patients, that are on heartworm preventative. I mean, for us, for the years I've been practicing, I've had more heartworm positive patients in the last 3 years than I've had in my entire career. And it's insane, to be like, you just never saw it. So again, it's kind of the same story, is that, you're exactly right. we do it accidentally, and I think it's again, it's not a fault thing. It's not the veterinarian's fault for having these services too high, and it's not the people's fault for not having enough money. It's that the entire infrastructure of our industry is so broken that it's like no one actually knows what to do. And
who's going to make the first move?
Yeah,
And
right.
Are we going to expect? Are we going to expect the caregiver, the consumer, to budget more appropriately according to the way that the market is, or are we going to take the hit on the front end on the veterinarian side and say, I'm going to take less, so that this problem starts to go away? Somebody has to pick.
Yes.
And I think what, again, we're referring back to the 2008's point. You hit a stalemate. It's like, I can't drop my prices because I'll go out of business.
Right.
And on the caregiver side, I don't have any money to spend.
Right.
So we just sat there and stared at each other.
Yeah, right. And then, people got mad. The caregivers got pissed off. The veterinarians got, the caregivers got pissed off at the vets. The vets got pissed off at the caregivers. Everyone was just angry all the time. And that's, I think, again, when we start to talk about then, when we start coming into these antiquated business practices, that's then where public relations went out the damn window, where then everyone's mad all the time. And you'll start to see veterinary groups, forums, wherever that happens to be, where all they're doing is just client bashing the whole time. Tons of non-veterinary forums of caregivers just bashing veterinarians. And then you kind of have some people in the middle where, there's caregivers where they're like, listen, guys, I know you're pretty upset about this, but it is not fair to really trash that veterinarian because that veterinary team, that technician, the staff, because they are trying to do good work and they're trying to do what they can, but they have limitations as well. And then it's like us on the other side. That's why I can't follow a lot of veterinary forums. There are some that I can, but some of them are where they're just so heavy on client bashing. It's just like, are you really that ignorant about your own actual part in this? And the answer is yes. A lot of, and that's why, of course, we're doing this and we have this industry overview, is that we all are playing a role. And it comes back to how we keep saying, and the repeated theme is, what's the solution? What's the implementation? And that's, again, as we start to kind of move through these outer blue bubbles of our industry overview, is exactly that, the solutions, and just saying, well, something has to give. Someone has to make the first move. And that's then kind of coming into our antiquated business practices. I mean, we've been talking about all these old practices. We haven't really necessarily focused on that one bubble itself, but I mean, we've been kind of touching on these business practices all along. But I don't think most caregivers really understand how antiquated veterinary practices are. And I guess
they know the difference because, like, the comparison would be human medicine. And understand. I actually was having a conversation with an individual who was an ICU nurse just the other day. And the thing that she kept coming back to was like, I have no issue paying for any of this stuff, but I completely understand why a lot of people have trouble in paying for just any veterinary service, is because the expectation from the human medicine side is that it's all subsidized by insurance. And that's why, I think I saw it on a forum the other day where, vets don't make as much money because there's no insurance in it. And like, why would I go to veterinary school when I can go to human medical school and make 10 times as much money? So like, there's the comparison between those two things, and just understanding that insurance is the one that I lean on, just because I don't have the doctor level exposure. It's just one example that a caregiver can see and say, well, clearly they're way behind whatever it might be. I don't like, or even services like CAT scan machines.
Which is
hilarious that it's called a CAT scan. I know it's not actually the medical term.
It's lab work and CAT scan. Right.
But like, those aren't available everywhere.
From one clinic to the next.
So the standard isn't quite the same, or whatever it might be. The access to the subsidized level of financial support isn't quite there. So I think it's there, but absolutely, caregivers as a general rule, they just show up. And they just like, my patient is either well or sick. Fix it and don't make me go broke.
But 100%. Yes. So I had a so one of the things we had talked about is Paw Health Foundation, right? So we've talked about having a nonprofit organization, that kind of stuff. I had a meeting with it was at a doctor's meeting, and this was probably like 10 years ago. I mean, easily, with one of the I was associate veterinarian at the time. It was another associate veterinarian in the practice. And we were basically having that discussion of, well, whose responsibility is it to pay for care if you can't pay for care? You know, and it was that thought is, you know, ultimately, if you have good insurance and you can't pay for care, well, the idea is insurance is covering that because you've been paying small amounts of insurance. That's the insurance game. Yeah. But because, like you said, it's not, and that is part of these antiquated business practices, is that there's at least 10 now. There's probably more, but honestly, there's so many different veterinary insurance companies now.
Oh, hundreds, honestly.
And that's the thing, like your major players in the game.
Yeah, there's 10 big ones, but there's a countless number of other ones.
Yeah. So that's then part of the discussion is, you know, for us to then as an industry say, no, there are plenty of insurance companies out there, but as a business, we haven't done anything to actually educate people that these things are available. You know, is it not in our best interest every customer every time to pitch insurance to them? I don't sell insurance. I don't have any stake in the game in that capacity, but I have a direct benefit in having these people be able to afford care. Yeah. And I think part of affordable care is I think there's some responsibility there, you know, in just saying, well, if we have insurance companies, the veterinary rates are going to go up by a factor of 10. I don't think that's responsible either. Right. You know, it's like, oh, well, just because we have insurance, we can start to charge more. It then is what is happening in sort of
human
the
medicine.
Human side.
Right.
Is
so
like,
when you don't have insurance, you go bankrupt.
You go bankrupt, which is not responsible. Right. So I think, you know, for us to, you know, sort of take this, you know, sort of, you know, insurance for all and, you know, preventative medicine for all, and, you know, some of these really kind of core concepts, it's not very popular for certain people within the political spectrum and the human side, but of course within the veterinary side, I think there is a way we can do it well. And that's, again, just all kind of talking about these antiquated business practices. There's plenty of people who come through our front door who have no idea insurance even exists in our industry. Yeah. You know, and I don't think, I'm not saying that insurance is the answer.
No, you know, it's one example.
It's one example.
Yeah.
Yeah. I think it's one example of these antiquated business practices. But getting back, you know, I said a few moments ago, is that most people don't really know how antiquated we really are. No. And a lot of it is really sort of on the back end. And I mean, you can talk very, very specifics about how sort of antiquated some practices are. Like, I'll give you inventory for one example. So our inventory process, you know, we use Covetrus for 95% of our business. Phenomenal company as far as supply chain, the people that work there, you know, sort of their business ethics, animal ethics. I mean, it's a great company. But for them, they say, okay, well, hey, we have this supply chain where you have an inventoried item, you sell that inventoried item as a product, and when you sell it, your inventory drops. Well, we have an entire software system that tracks your drop. So when you go below a threshold, it's going to kick out a purchase order. The purchase order is going to go for reorder. And then guess what? That's going to come back to your company electronically for you to then receive this particular item. But guess what? When you receive it, it's updated pricing right then. Yeah. So that type of system is very manual in almost every other practice that you go to, where it's you have one person whose job is to go around and count drugs. And that's what they do every week. You have one, you know, maybe that same person's job is to then manually generate purchase orders where they have to go onto the website. They go onto the website to then tally off and saying, I need 1 bottle of this, and I need 2 bottles of this, and I need 4 bottles of this, and I need, you know, 6 bottles of that. Yep. I need this stitch. So their job is then to have that ordered. And then when the items come in, maybe they update the price rate then. Maybe. But it's very possible that depending on the pricing structure of that particular veterinary clinic, that they just flat rate this drug. Like, we'll use a steroid as an example. So prednisone is, I don't know, probably a couple cents a pill. Well, I don't care what the price of prednisone is from the vendor. I'm just going to sell it to you for $1 a pill. I don't care, because for me, I'm going to sell it and I'm not going to waste the time to give updated pricing on this particular item. That is one very focused example of an antiquated business practice, which is pretty much the standard in a lot of your definitely monument practices, you know, kind of these old kind of traditional type practices. But really when you say, no, we have like our inventory system when I first started at this clinic, as well as 10 years before we were an owner, is that the inventory thing was about maybe a 15-hour a week job, 20-hour a week job, something like that. We've got it down to, I don't know, 45 to 90 minutes a week. So in that example, right? So so we talk about lack of infrastructure, right? So this is just inventory. We're not talking about anything else. So if we just use this as one inflated example, which we may be getting too specific into this particular antiquated business practice.
Good example.
It is a good example. Is that here's the concern. So now you have person who had a job at 20 hours a week, and now the computer system is replacing them. Well, what now? Well, that's my job. Those are my hours. You're cutting my hours. You're cutting my pay. So then where is the incentive to advance a business practice if it's going to affect the clinic culture that you as a business owner are now cutting people's wages because the computer system does better?
Yeah.
And it's like, well, we can find other ways for you to get hours. There may be other things in the clinic we need to work on, like culture, like training, like any of these other things that we've been talking about, engagement. There's other ways we can find you to get hours and you to make wage, but the business moves forward.
Yeah. Going back to our discussion on culture again, and it's funny how so much of this is based around this. We keep going back to it, and maybe it's just because I see so much value in it. I don't really know. Regardless, what you're saying is the culture of a practice is holding on to its shoestrings, and if you mess with it by saying nope, we're gonna do better,
right,
and you blow your culture apart in that way, your culture wasn't good.
Yeah,
like, it's flat out. So if that's your decision making process, go back to your culture.
Yeah,
because you have to improve that so that you can do this. These things all interconnect.
Yeah,
there's some major interdependence with all of these variables.
Yeah.
And that's just, it's kind of sad, honestly, that level of decision making would be included, because I am very much a capitalist.
Sure.
And if the idea of halting business progress for the sake of holding on to whatever means of culture you might have, to me, is kind of sad.
Yeah, no, and I think it's certainly not a platform for us to talk about our political stuff. I mean, I lean a bit more towards that democratic socialist side, where it's unity and doing these things together, and there's ways we can level the playing field on certain things. But you're exactly right, is that we are talking about business decisions ultimately made for cultural reasons. Yeah. And I'm not saying that it shouldn't go the other way. There is, and you have to improve culture. You have a lot to gain as a company.
Yes.
That is definitely true. But what I'm referring to is kind of like what we had just said, is that, when we start to then say, okay, well, I can't improve this part of my practice, which is better to serve the patient, because I am afraid of what it's going to do to the staff. Like you said, there's a bigger problem there.
Yeah, you're the business decisions that you have made in the past in terms of improving culture have been proactive in advancement. What you're talking about is a lack of reaction out of fear.
Yes.
So those are two very, very different things, regardless of your political affiliation.
Right. Yeah. And I had one of CEO of the company that used to own us, I was talking to her, we can have lunch, every couple of years or whatever. So, I met with her and I said, there's certain things about this that I don't understand. Like, running a business is difficult. I'm not saying that, but it was always sort of pitched to me that it was more difficult than what I'm currently experiencing. And that was one of the things I'd asked her. And I said, I just don't understand why some of this stuff is easy, with the culture, with making a business decision that is going to affect the staff negatively or positively, but either that positive or negative staff impact is to improve patient care. And then in the long run, even if you have a negative impact on the staff, those people with whom the impact was negative probably don't and shouldn't have been with your organization. But then the long term is that our goal is to serve patient care. Yeah. I said to her, well, why? I don't understand. Why is this so difficult? Like, why is this pitched as being so difficult? And she kind of made the joke. She's like, well, you're not afraid to fire people. Yeah. And we said that before, and it's like, well, I don't want to fire people. I don't want people to have less hours. I don't want to have, like you said, a culture of fear in the other direction where, I am, as a business owner, culturally, or I'm fearful of my employees. Same thing. I don't want them to be fearful of me. It's a level playing field. If we're talking about leveling the hierarchy of an organization, is that is also administratively dropped, where we are here as equals. I am paying you an appropriate rate. You are doing service as appropriately aligned with our company. No one's in debt to one another. There is no fear.
Right.
So that's then when we start to, really back down to it. Like I said before, with this sort of, there is no blame, and in so many different walks of this, it really boils down to taking it back. What are we actually here for? Oh, well, we're here to serve the patient. So if we're all here to serve the patient, then we can sort of build up from there.
When you level the playing field, you have your horizontal organization structure. Everyone's on the same plane. What that does is it literally and figuratively at the same time says, okay, that means we're all here to do the same thing.
Yes.
Like we've left our concerns at the door. That's why we're all here. And when I actually I did an interview with Annie on the other day, and I talked a whole bunch about that, and because he had come from some larger organizations, and there was a little bit of you could tell, like, resentment from managers and all that sort of stuff, and I was like, I understand that your reaction to that comes out of a very valid place, because you were in this massive hierarchical structure, you were given no autonomy, all that sort of stuff. We don't do that here. This is the way that it works, and the reason we do that is to serve the patient. But ultimately, what that does is when people don't do that, they stick out like a sore thumb.
Absolutely.
And this is what we do. We just either say, fix it,
right,
or you're gone.
Right.
And it's not because I don't like you.
Right. Oh no.
It's just because this is the way this works here.
Yeah.
And if you're not okay with that, I'm okay with you leaving.
Right.
It has nothing to do with animosity, resentment, anger, anything like that. It's about maintaining the culture so that the business practices can continue to advance.
Yeah, absolutely. And see, that's the thing. Like for the employees that are present, it then becomes a level of favoritism, where it's like, well, this person is coming into the organization. We are all held to this high standard of patient care. Like, and that's the thing. Like, I think people are afraid of, like, oh, well, this is how you do it here. If you don't like it, you can leave. It's like, hold on a second here. We're not talking about crazy stuff. No. We're not talking about irrational policies and procedures where you have to follow something just because we say you do it and you need to have it done. Is that we have constant feedback from staff at all time. I mean, that's why we have our 4 core development team. We have separate groups of people who just keep a pulse on the clinic to say, this is working, this isn't working, this is a problem, that's not a problem. Hey, that was a great solution. Guess who came up with that? Oh my God, that person needs praise because they came up with an amazing solution for a problem. We're not just saying it's this, again, it's the horizontal part. It's not a top-down structure. It's like coming back from what we had said several ago. We have a tree we need to grow.
Right.
We have a massive redwood in California that needs to have a massive root infrastructure, that needs to have a massive trunk. We're talking about growing this together. And that's where we kind of start talking about, well, if you're going to stick out like a sore thumb if you don't integrate into this process, but it's because of what we're doing. We're leaving the profession. We're not in the eye of the storm. We're not walking with the entire profession, because we know that most of what is staying in the middle of the eye of the storm is antiquated business practices. As we're saying, it's cultural issues, it's talent issues. We're jumping out and saying, nope, we have a completely separate thing, which is pulling from experiences and processes and procedures from other industries that have worked in other industries that we're just applying in the veterinary profession. And oh my God, guess what? It's working.
Right.
If you don't like that, I really am sorry.
Yeah.
But I'm sorry for a couple other reasons. I'm not sorry because we're doing it wrong. I'm sorry because it's actually kind of sad. I'm sorry because there's an institutionalized component to it. Like, you actually can't see the benefit that we're bringing to the table for these patients, for their caregivers. You can't actually see how, if you can just get over yourself while the time you're in this building, while you're in here working with the team, it's sad that you can't get over that.
Yeah.
Because we're not an organization of, yeah, fine, we are a corporation, but we're not a company of people who are just handing out orders.
Right.
These are real world solutions to real world problems. And ultimately, at the end of the day, we are creating infrastructure for the future. We are creating infrastructure to be replicable at so many different levels as it's applicable to the environment and the location where it is instituted.
Right.
There's not one size fits all. It's guidelines, and it's structure.
Yeah. One thing that I'll add to it that you and I have actually never talked about before, because I just saw it the other day. You ever heard of the book called Bullshit Jobs?
No.
The individual that wrote it, his name is David Graeber, I believe is his last name. And what it's called Bullshit Jobs, a Theory. So there's not a whole lot of scientific substance to it, but what he's talking about is this idea of multiple industries that have horrifically antiquated business practices, and veterinary medicine is not included in it. But the concept
We
is
should send a note to the editor, a letter to the editor. Yeah, okay.
Here's number 6.
Right.
But basically there was especially in these very, very large corporate structures, multiple jobs were created just to facilitate some of these other value added jobs. It's the idea of the accountant serves the salesperson, essentially.
Sure.
And what it is that those jobs are essentially bullshit, because if you remove that person and you remove the regulation that maybe forced that job doesn't matter anymore.
Sure.
So it's the idea of that is a complete removal of autonomy.
Mm-hmm.
That is, you're here to serve this purpose because 2 other people required it.
Gotcha.
You have no leeway one way or the other.
Yeah.
And what you're saying is, too, like a lot of the people I think that have a hard time grabbing onto it is they're so used to the idea of I'm going to kind of just fit into this bullshit job model,
right,
which is going to allow me to work 30% of the time and just collect a check the other 70% of the time, because it's just limited engagement, limited value.
Yep.
That doesn't exist.
Yeah.
I mean, I don't know if I've ever worked harder in my life.
Right.
Because there's constantly something to do.
Yeah, always.
And it's across the board with all of our positions. If you're in the clinic, there is little to no sit around time. No. I mean, it does happen from time to time, and it's kind of nice to take a breath, but it's definitely not a 30% work, 70% wait.
No.
Or as he likes to put it in the book, a 70% look busy, because you're trying to justify your existence. You're trying to just sell your boss on why you should continue to get paid. Yeah. And for us, it's like, no, I need to sell these caregivers on like just pause. I promise I will get to it. There's so much work for me to do.
Yeah.
I need to get through this triage order. It's a complete flip on it. So I'll put a link in the description for the book. And I'm sure we'll explore it again at some point. But it's a pretty cool idea that we naturally just said, no, we don't do that.
Yeah. And that's the thing, was that coming back to our inventory as sort of our one isolated type business practice, here's the reality. So we had one person whose job was to handle inventory, or this individual had multiple jobs, but the idea was that at least half of the job was spent towards this one particular task. Basically, we grabbed hold of it and said, this whole thing needs to get fixed, and it needs to get streamlined, it needs to get improved, and just inventory management. So mind you, we had maybe some change in consistency in markup. So it wasn't like, this 5-cent pill is $1 and this 5-cent pill is 10 cents. It was that all of the pills are marked up the same amount across the board laterally, and then also supplies and stitch and all these different types of things. So that was one of the things when we took over. September was our first month, and I was like, I was like, I'm just trying to learn the computer system, and I'm trying to learn how everything works, and and I identified that immediately. We had tons of other stuff we needed to do from a business standpoint, but I was like, oh my God, we don't know how much stuff costs. And I was like, okay, all right, how can I fix this? I didn't even know that it was a problem when we had originally took it over. Right. I said, okay, all right, here's what we need to do. That whole month, all of September, all I did was fix inventory, and it wasn't, and it was like 40 hours on top of the 60 I was already working. It was an insane month. Yeah. But just doing that, our prices started, they weren't spiking so much. They started just towards the end of that year 2015. They started to sort of plateau because we didn't have these huge swings in our estimates for when caregivers were coming through. But the company that, just in doing that, in quarter 4, which October, November, December, in quarter 4, we profited the same amount that the company did in the whole year prior, just in inventory management.
Oh,
just in inventory management, which is an insane thing to say. Our prices didn't go up. If in some circumstances, prices actually came down.
Okay.
So that is one clear, tangible, in hand. This is what happens when you fix this one antiquated business practice. Maybe not in every clinic,
Right.
but it was a start example saying, no, we say we talk about these jobs, you take these jobs away, and as soon as we streamline this and this job no longer becomes necessary, we're talking about just fixing a process.
Right.
And that for me, I was hooked. Right after that, I was like, wow, I did one thing for this practice and look at what it did. Now, because I did that, this money that we gained, health benefits, increase in pay, increase. We had all of our equipment started getting, between all our new machines, fluid pumps, all this stuff. It was just keep investing into the company, and it was all because we fixed this one antiquated business practice.
I just want to make it abundantly clear because I just want to make sure that you and I are on the same page with that statistic. Q4, your gross profit number, the actual number, not a percentage, was equal to that of the original 3 quarters.
Net.
Yeah, your net.
Yes.
It wasn't the percentage.
Yes.
You didn't say it was 15% for these 15%. It was I made
yes.
a 1,000 as a number
yes.
for the first 3, and then I made another 1,000
correct
for the last one.
Correct.
That's ridiculous.
That's
because of one process.
One process.
Yeah.
That is what happened. I mean, close. I mean, we were probably net profit wise, whole company prior to maybe my stat is $10,000 to $12,000 off on profitability.
Yeah.
But when you're looking at it from damn close,
yeah,
in just fixing this one part,
yeah,
that's where it's like, not only do we have a lot of work to do, but guess what? Black and white, I did one small thing. It significantly improved the health of the practice, and it's going to significantly impact the health of the employees in the practice.
Right.
And that's where Katie and I, we said for the first 5 years, we're taking this much money from the clinic. It's all going back in. And then that's now where we're on the cusp of a brand new 11,000 square foot building because of these things.
Right.
It's prices down. Focus on the middle 60%, make things affordable, make things available to caregivers, and ultimately in the end, just start to anticipate ways in which we can fix problems for people who don't even know that they have the problem yet.
Right. That's okay. You just, that was one of those moments right there.
It's probably honestly a great place to sort of end.
It is, because really what we're saying there is, all right, we now have a very detailed in a long format picture of a whole lot of problems that we've now understood. Yep, they're all very interconnected.
Very much interconnected.
Because the more it's a spiral. You can either go up or you can either go down, and they're all going to impact one another.
Yep. This is the center of this industry overview right here is, I mean, when you look at it and you just walk around it clockwise like we just did with our video series here, it's a friggin' cyclone.
It is.
It just keeps going. The center of this is the storm, and we as a profession are right at the pinpoint part of culture, service, and talent, and there is no space there anymore. There is this whole thing is just one massive problem, and that is our spiral. It keeps going. Antiquated lack of infrastructure to failure bond spectrum to loss of talent to lack of infrastructure, and it's just going and going and going and going and going. And this is why the industry overview is so important.
Yeah. So my question then, from an individual who developed you saw the problem, and now let's say I'm a veterinarian clinic owner. I want to do all of these things. Let's say I'm willing to say I'm going to be a vet for 60 hours and I'm going to put in the extra 40. I'm going to start to bust my ass for the next 5 years.
Yeah.
Where would you say, and I know the answer is all of them. But this is going to lead us into our next episode is what's the next thing? Where do you put your effort in first?
100% core values and culture.
then that's where we kick off next week. Awesome episode, Carl.
All right.
Yeah, so that means that everyone should tune in next week. We're going to start to dive into our core values and into the cultural solutions that we've put in place here at Paw Health, and hopefully will help you provide some impact in your own clinics. Anything else, Dr. Carlo?
No, that'll do it.
Awesome, man. We'll see y'all next week.
All right.